Now, what is the journey of the clinical trials on which heart failure therapy is based? This is a very important thing for us to understand that, as I told you, that initial treatment for heart failure was reduce the fluid intake, give diuretics, give digoxin, and rest, and correct some things like anemia. This used to be the treatment for heart failure. Now, since then, the treatment of heart failure has progressed. And as this slide shows you, that the first trial which showed advantage was hydralazine and isosorbide dinitrate. It was a very simple concept. Isosorbide will dilate the veins and reduce the preload. Hydralazine will dilate the arteries and reduce the afterload. So the weak heart has to deal with less amount of blood coming into the heart and less amount of pressure against which it has to pump. So the heart failure would be elevated, the heart's remodeling would be prevented. And this was the first evidence-based therapy for heart failure, where which we could reverse the vicious cycle of heart failure. Then the next landmark trials like SALT and BHEFT, they showed the role of angiotensin converting enzyme ACE inhibitor benefit. What was shown that drugs like enalapril, ramipril, when is given to a patient, they are causing vasodilation. They are favorably affecting remodeling, delaying or preventing the signs of heart failure, and more important, they were preventing deaths. So, reducing mortality, reducing morbidity. It was a great achievement. Then came the trials which showed the benefit of the MRAs, aldactone. This was the first, the RAILS trial. This showed that there was a benefit in giving mineral corticoid aldosterone inhibitor at a dose of 25 milligrams a day. It showed a definite increase in survival. And also, people used to be very worried that it will cause hyperkalemia. It was found that ACE inhibitors and mineralocorticoid receptor antagonists, their propensity to create hyperkalemia is just under 10%. So they are safe, but they need some monitoring. Then came beta blocker. Beta blocker is very simple. When the heart is failing, the body is trying to flog the failing heart. What is it doing? It is causing large amount of release of catecholamines. They may be circulating catecholamines in the blood or discharged from the sympathetic nerves. So the receptors in the cardiac myocytes, they get down-regulated. So when you block the beta, those receptors, what happens is they prevent the down-regulation of these receptors, and they protect the myocytes from this shower of catecholamines. They prevent apoptosis. They prevent the acceleration of the disease, and they increase survival. So this was proved in multiple trials like Copernicus and Merit and Cibis, and has again become one of the cornerstones of treatment of heart failure. Then, of course, our old friend digoxin. Digoxin was the first treatment. It came as some few leaves which were given to the patient to improve their survival. We also know that surgery, angioplasty, the use of ICDs, pacemakers, combo devices, left ventricular assist devices, and even cardiac transplant are available to improve the survival in heart failure. But the most important, one of the most important molecules which came is RNA. We will be discussing at length about this molecule now. This big step forward came as a result of the paradigm heart failure trial. So by using this combination of valsartan with cyclopentone in very sick people who were many of them in NYHA class 4 with severe LV dysfunction, for the first time we saw an amazing jump in reduction in cardiovascular mortality, hospitalization for heart failure, and it was one of the great achievements of the last decade that we could find suddenly a molecule which provided us with a good survival benefit. And on the basis of this landmark trial, this drug was given FDA approval for treatment in heart failure with reduced ejection fraction. So, what was the eligibility criteria? People who had a low ejection fraction of 35%, who had clinical signs of heart failure, who had elevated biomarkers of heart failure like NT-proBNP. These were the people who were taken in this trial and given either the ARNI or an ACE inhibitor, which was enalapril, along with beta blocker and diuretics and other standard therapy for heart failure. And what was found was that in every aspect, whether it was resolution of the signs and symptoms of heart failure, whether it was increased survival, and even when it came to arrhythmic death, it is very important. This is not an anti-arrhythmic drug, but even the arrhythmic death, sudden cardiac death, is reduced in patients who are put on ARNI.